Hello friends, good evening. Today we are going to discuss about diabetes in pregnancy part 1. In this case we will discuss in under the we will study diabetes under the following topics. First of all, we will understand the carbohydrate metabolism in the pregnancy. Second one is gestational and pregestational diabetes. Third one is white classification. Next one is diagnosis of gestational diabetes, ADA or IAD-PSG criteria, ACOG two-step approach and DIPSI criteria. Antenatal care of the GDM patient, medical management of gestational diabetes, obstetrical management of gestational diabetes, and postpartum management. First of all, we are going to study the carbohydrate metabolism in pregnancy. In pregnancy, fetus depend upon its glucose requirement depends upon mother for its glucose requirement. That glucose goes into the fetus by the facilitated diffusion with the help of GLUT1 and GLUT3 receptors. During pregnancy, insulin secretion increases and insulin resistance is also seen in pregnancy. Main hormone responsible for insulin resistance is human placental lactogen, and the other hormones are also responsible for insulin resistance are progesterone, GH, CRH, and cortisol. But the hormone not responsible for insulin resistance is SCG. This human placental lactogen is secreted by the syncytial trophoblast of the placenta, and the one quality is this human placental lactogen increases continuously throughout the pregnancy. And human placental lactogen secretion increases throughout the pregnancy, so insulin resistance also increases, and at 24 to 28 week it becomes significant insulin resistance is seen. And then this significant insulin resistance may lead to GDM. Significant insulin resistance may lead to GDM. And so screening is must be done at 24 to 28. In every female, pregnant female, we should do the screening of GDM at the 24 to 28 week. And what does now we should also know what does hyperglycemia do in pregnancy? Why hyperglycemia is very dangerous to our fetus or our pregnant ladies? Hyperglycemia that releases free radical, and these free radicals are phytotoxic and lead to congenital malformation. But this is not seen in the GDM. What happens in GDM? In this GDM, this insulin resistance that develop at the age of 24 to 28 week. But you know that organogenesis is completed in the first trimester. So organogenesis is over. So GDM that does not lead to the congenital malformation. But in diabetes, this hyperglycemia release free radicals and it becomes phytotoxic, and it result in congenital malformation. In pregnant female, in fasting cases there is hypoglycemia. Why there is hypoglycemia? Because fetus is dependent on mother for glucose requirement, but there is postprandial hyperglycemia. Why? Due to the insulin resistance. So when glycosuria is normal in pregnancy, this should be noted. And the diabetes in pregnancy, there are two types of diabetes. There is gestational diabetes and pregestational diabetes. What does it mean? Pre-gestational diabetes means there is a known case of diabetes mellitus, and this is diabetes mellitus prior to pregnancy, and this pregnant female conceives. So this is called pre-gestational diabetes, and blood glucose level increases from day 1 of pregnancy, and free radicals also increases from day 1, that lead to the congenital malformation. But in case of gestational diabetes, the pregnant females are normoglycemic before pregnancy, and they become diabetic due to the insulin resistance, and at the age of 24 to 28 week. This free radicals, or is this high glucose level that formed at the age of 24 to 28 week, so there is no chance of congenital malformation. Thank you.